Mitral regurgitation. Etiology, pathophysiology, and pathology. Abnormalities of the mitral valve annulus, valve leaflets, chordae tendineae, papillary muscles, or adjacent left ventricular, LV, wall may cause mitral regurgitation, MR. NB. Common causes of MR in the adult. Idiopathic mitral valve prolapse, MVP most common cause. After myocardial infarction. Papillary muscle dysfunction, ischemia or rupture. Ruptured chordae tendineae. Annular dilatation, ischemic heart disease or dilated cardiomyopathy. Rheumatic heart disease. Infective endocarditis. Atrial septal defect. Failure of valve prosthesis or paraprosthetic leak. Epidemiology. The prevalence of MVP varies from 1 to 6%, and is twice as common in women. After myocardial infarction, the prevalence is 20%. Clinical presentation. Common symptoms include exertional dyspnoea, orthopnoea, fatigue, and lethargy. Occasionally, there are palpitations and, in severe acute MR, the patient may be very unwell with severe dyspnoea. Physical signs. In mild disease, there are few signs apart from an apical pansystolic murmur radiating to the axilla. In more hemodynamically significant regurgitation, there can be the following. Atrial fibrillation, AF. Laterally displaced, hyperdynamic apex beat with systolic thrill. Left parasternal late systolic heave, atrial filling, in severe MR. Soft first heart sound, wide splitting of the second heart sound, and a third heart sound. Late systolic murmur in association with a systolic click suggests MVP. In acute severe MR, there is poor perfusion with pulmonary edema. A murmur may not be heard due to very rapid equalization of pressures between the left atrium and left ventricle during early diastole. Investigations. ECG. This may be normal, but look for AF, left atrial enlargement or LV hypertrophy. Chest radiograph. This can be normal, or may show cardiomegaly with left atrial enlargement. Mitral annular calcification may be seen, Fig 57. There is pulmonary edema in acute MR. Echocardiography. The presence of excess leaflet motion, restricted leaflet motion and annular size must be carefully assessed with both transthoracic and transoesophageal echocardiography. In the case of prolapse, a precise assessment of the scallops involved is required. Severity assessment is semi-quantitative from color and continuous wave Doppler. Measurements of left and right ventricular size, systolic function, and pulmonary artery pressure are required, Fig 58. Coronary angiography. Coronary angiography may be required if there is a suspicion of coronary artery disease. Dynamic assessment. In patients with ischemic MR, baseline MR may only be mild to moderate. However, during exercise ischemia of the papillary muscles and adjacent myocardium may cause the MR to become severe. Exercise, stress, echocardiography should therefore be considered in patients with ischemic heart disease and severe cardiac symptoms that cannot be explained by baseline MR or any other cause. Treatment. Emergency. Treat acute pulmonary edema and shock. Vasodilator therapy reduces the afterload and is of benefit. Intravenous nitroprusside may be life-saving. Urgent surgery is required. Short-term. Symptomatic patients with severe MR who are awaiting surgery should receive diuretic and vasodilator therapy. Digoxin is of particular benefit in the treatment of AF. Anticoagulation will be required. Long-term. All patients should receive antibiotic prophylaxis. Mild to moderate disease requires annual monitoring only. All patients with symptomatic severe MR require surgery. Asymptomatic patients with severe MR should be referred once LV function starts to decline or LV dilatation occurs. Generally, surgical outcome is better with mitral valve repair than replacement. NB. Indications for surgery in severe MR. If surgical repair is possible, it should be considered in all patients aged less than 75 years who have a flail leaflet or persistent AF. Deteriorating ventricular function, ejection fraction less than 60% or end systolic diameter more than 45 mm. The presence of symptoms, although careful consideration of the etiology and severity of LV dysfunction is needed in older patients. Complications. The following are possible. LV failure. AF. Infective endocarditis. Pulmonary hypertension. Right ventricular failure. Thromboembolism, more common in MVP. Sudden death, more common in flail leaflet. Prognosis. Progression of MR depends on the etiology, but it develops in 15% of patients with MVP over 10 to 15 years. Without surgery, patients with severe MR have a 5-year survival rate as low as 45%. After surgery, the 5-year survival rates vary from 40% in MR caused by ischemic heart disease to over 75% in rheumatic mitral valve disease.